Andy, thanks for joining us in the
problem.
podcast studio.
Thank you. Yeah,
and
it's great to be
Trauma
here.
Society
Yes.
meeting, more importantly.
Yeah, that's
This
right.
is our first time in Scotland in almost 30 years.
Okay.
So I just wanted your view on the BTS meeting with the STN collaboration.
Yeah, I mean, I think it's, I've not been at the BTS for a while. I've been involved more with the Orthopaedic Trauma Society. So firstly, I think it's great the two societies are sort of linking back in. That's the first really positive thing. Obviously, as a previous Edinburgh trainee and Scotsman now living, albeit in the northeast of England, it's great to be back here. So genuinely, I think that's been good in terms of just seeing where Scotland's at, because it was kind of lagging a bit behind in terms of the trauma networks. It was initially set up in England, and I know there was a huge amount of debate in Scotland about which of the centres should be a major trauma centre, given a population of 5 million, but obviously geographically over a big area
really
with a very centralised population. So it's been interesting to learn about that, and so I've enjoyed it.
Absolutely. And we just had Tim in, and we were speaking about the advantage of coming in last. Actually, there are some advantages because you can capitalise on all the lessons and pains everyone else has gone through. And obviously Tim was brought up from a UK major trauma centre, so he'd seen that problem. And I think to me it's been hugely valuable. And the collaboration with Orthopaedic Trauma Society. So you're the incoming president next year. So you're
president-elect for OTS. So I was involved in the initial kind of setup of the society about 12, 13 years ago, and then got back involved a couple of years ago in terms of doing their comms and website. So sort of president-elect, and just trying to make a real effort to get things going again, not just about our meeting, but just try and get the website, organising stuff with industry in terms of linking in with what is a lot of really good resource that's already out there, and just making that available, because it's just sometimes people just don't know that it's available.
It's a perfect pivot into my next question, which is technology and the advantage you can provide for our patients. So big data collection and technology. Where are we now with that in major trauma and trauma cases, whether it's orthopaedic trauma as well?
Yeah.
Where do you see the future of it being?
I think there's lots of. It's a really good question. What big thing that we've seen? So older trauma. So major trauma now, your average age I think is about 55. So we're dealing with older patients. The first thing to say is I've been involved with a lot of fragility fractures over the last 5 years, and there's a lot of AI tools that is going to really help us with regards to that. So in terms of using databases, looking at patients that are perhaps high risk of fracture and identifying them and starting them on appropriate falls prevention and bone health medication to actually get in at the start before they go down that deterioration of more severe major osteoporotic fracture, so getting in early. So I see AI as being a key tool in patient identification, and just us being aware of our patient population and who we need to target preventative treatment with first. Obviously, there's big advances, at the coalface in terms of the surgery that we're doing. Certainly from an orthopaedic point of view, the implants that we now use in terms of their technology and the ability to fix fractures more effectively as being a major advancement. And to be honest, one of the reasons, it's great fun to do. We've got lots of interesting patients. You don't want to be an interesting patient, but they are. Big developments, I think, are the use of arthroplasty in terms of difficult fractures. So, for example, a multi-centre study in Sweden showing that in low demand elderly patients, the reverse shoulder replacement in terms of function was outdoing fixation. So there's the surgery side of things we're advancing. Major trauma's interesting. I'm not, there's obviously advances that are occurring, in the terms of assessment of major trauma and their triage. But we produced a sort of paradigm shift in treatment back 10, 15 years ago when we moved to these trauma networks, having all the specialties under one roof, reduced our mortality by something between 20 and 40% for these seriously injured patients. So we have to tinker with that and improve it. I think we're up against it. Our older patients are frailer. They've got more medical comorbidities. So actually just maintaining our current level of mortality and morbidity is going to be a challenge. So for example, the White hip fracture study recently published on 25,000 hip fracture patients, and serious complications, morbidity, mortality was around about 12% at 3 months. So maintaining that is going to be a challenge. So it's a great area to be involved with. It's really interesting. It's kind of a privilege, I think.
You mentioned you've seen changes in your career It's been,
Yes.
I'm not alluding to your age, but it's been a couple of decades or so of
Yeah,
trauma,
no,
trauma experience.
it passes very quickly.
More. What's the most important change you think you've seen in that time that's affected trauma patients? You may have covered it because you mentioned earlier about...
Yeah, I think, the game changers for me, there's been a lot of changes. First of all, I think I was very fortunate when I came in as a consultant in 2009, and perhaps 3 or 4 years either side of that in that orthopaedic trauma really expanded as a specialty. We had people like Keith Willett and Chris Moran who were kind of driving the thing. There was a lot more trauma fellowships, and we had a great group of people who were young consultants at the same stage of their training. On the back of that, I think the two main things, the first thing would be the development of the trauma networks. So that really, the major trauma centres developing, specifically in England at that stage, was brilliant. And the improvement in results, as I say, that paradigm shift in serious patient mortality, reducing it by somewhere between 20 and 40%. The second thing is probably the hip fracture stuff, the National Hip Fracture Database, and the improvements that so those kind of gold standards for fragility fracture care, which we could expand to all fragility fractures, to be honest, and that's orthogeriatric input, immediately has been a game changer in terms of improving patient mortality. Immediate and unrestricted weight bearing, the right type of surgery, making sure that you're honest in terms of the right type of implants for certain fracture patterns with anaesthetic input in terms of nerve blocks and making that whole rehabilitation piece better. I think that's what we need to work on, is actually what happens after the surgery. So it's about effective rehabilitation, what works, because it is very expensive.
Common theme.
A recent study, in I think it was the New England Journal of Medicine, with a major, and I'm sure quite expensive, outpatient physio intervention to try and prevent falls and fractures didn't actually make much of an impact. So we've got to look at how we improve that side of things, and the whole secondary fracture prevention piece. I've been working over the last 5 years with an organisation called FAN, which is the Fracture Liaison Service Academy Network. So what we're trying to do is, in more remote areas of the country, and FAN, the world is making what fracture liaison services available, making them more effective, and actually starting FLS services where they don't exist. The UK is actually the gold standard. Although we've only got 60% geographical coverage, we are actually better than most of the other developed countries, never mind the developing ones.
Nice to hear.
And the government's committed to FLS coverage, 100% by 2030. So whether they can deliver on that effectively, I think is going to be a challenge. So so those are the kind of changes that I've seen.
They've been game changers.
Yeah.
Perfect. While we're talking about sort of careers, what advice would you give to somebody who wants to come into medicine now? Is it still a worthwhile career, and if so, why?
Yeah, I think that's a really interesting question, because I hear a lot of negative stuff about that I wouldn't. I've got 3 kids. They're all age 14 to 20. None of them want to do medicine. That's not because I've talked them out of it. Look, I still think it's a great career. What are the positive things? The people you meet. You meet great people. You get to work. It's a bit of a cliche, but you work as part of a team. It's a very privileged position still in terms of how people treat you. And it's, I still think it's a fun career. I play a lot of golf. I love golf. Still, coming to work for me, if I'm doing an operating list, is like going to the golf. I mean, that's how I think about it. Okay. It's great fun. It's maybe not quite as good as it was. As I've got older, got a bit tireder, maybe not quite as much energy levels. I think the turnaround, the hospital efficiency, especially after COVID, has deteriorated. I think that's taken the edge off things for a lot of people. I feel a bit sorry for the trainees. They're not working as... I was part of a team. I was looked after. I was given a hard time sometimes. I was looked after. They've lost that now with the and they feel they look a wee bit directionless, and I feel a bit sorry for them sometimes. There
was a community of medicine, and as you said, you're part of a team. We're trying to reinvigorate, restructure that.
We can, but you come to meetings like this.
Quite challenging, but
the BTS has been great. I think it was one of its criticisms in that it's fairly low ball papers from juniors, but actually it's giving them a forum to speak, to get involved, to get motivated to do better stuff.
If you want to inspire someone, if you genuinely want them to change a career path, or once they're ST3, they're committed.
Yeah.
And the likelihood of them then sort of being able to shape them very much changes.
Look, it's tiny things. I look back in my career. I'm 54 in a couple of weeks, and I started medical school in 1989 when I was 17, and had a very very bad experience with orthopedics. I went to an attachment for a month and they really weren't interested in us at all. And I thought I actually ticked orthopedics as something I'm definitely not doing. So I then come back after doing a year in Australia, doing emergency medicine, which was great. Doing emergency medicine in Australia was a brilliant experience. That was after my house job, so that was about 1998. And I started work at Ayr Hospital. And at the time, there was a very junior consultant there called David Large and another consultant called Andrew Muirhead. And they were inspirational. They set up lunchtime. Every lunchtime we got nice soup and sandwiches. They did a teaching session for half an hour. It was protected time. We protected study leave time. And it was just really motivation. I mean, David Large went on to be head of the training in the UK. And he actually, I remember him saying to me, Andy, he said, if I won the lottery, I'd probably stop work, but I'd still like to train. Still like to train. So it's that. So it's like, that's, and it spreads. Yeah. So that's, and then for me, a game changer was going and just changing environment as well. I'd been in Glasgow for years and I got the opportunity to go to Oxford for 6 months. Yeah. And there I met a number of great consultants, Keith Willett and Peter Warlock at the time. And that 6 months inspired me to do orthopedics. I was meant to go back to Glasgow, which is my hometown, and I had an interview in Edinburgh 2 days before and got the Edinburgh job, and there was able to do my MD, which I presented the work on today, and from there came the fellowship and where you end up. So it's these kind of sliding door moments as the junior. You've just got to look at it. And my advice is don't shut any doors. I've been amazed over the last year and a half working again with the Orthopaedic Trauma Society, just speaking to people about that, making the extra phone calls, sending the emails and engaging with them, what's come back. It does inspire you about people because they're very positive. They will help you and do stuff if you ask them properly. And they can see that you're going to follow through in it as well. So for me, that's been a game changer. I mean, that's the only reason I'm here today as the president-elect. Is 18 months ago, I made a conscious decision that actually I was going to put this back in the radar. Amazing. And create time in my week to do it. I was fortunate enough in that I was at the stage in my career where you could do that, but you have to work hard to achieve that. And people say, well, you're very lucky that you've been to these nice places in the last year, but that's only because there's been 30 odd years of work to get to that stage. So you have to take advantage of it now, because it's once you're in your early 50s, it's a dangerous age. Absolutely. We've lost, we know 2 or 3 people that have passed away recently, and you've got to make the most of it. So I just try and focus in each week, try and get the most out of each week, without being silly about it, obviously, and very much trying to live a bit more in the now. Yeah, absolutely. So, and I think, I mean, I like you. I'm a strong believer in paying it forward. You've got to look after your juniors, and I've got a reputation for being slightly biased because all I do is trauma. Yes. And so I usually say to trainees, if you've got a project, you want some advice. So you pivoted really nicely to 17-year-old going to university. So my question is going to be, if you could give 18-year-old Andy Gray any advice, what would it be? Oh, that's a big question. I wish you'd asked me that last night so I could think a bit more about it. I think big thing for me is know your weaknesses. Don't make quick decisions. You've got time to consider your options and make the correct decision. You're probably aware, I think it's I can't remember the author, is it Kahneman? Daniel Kahneman talks about fast brain, slow brain. Okay. So to me, a lot of my decisions when I was younger, and even now, I feel myself, I'm quite reactionary. I want to make a quick decision. And actually, if you take a bit of time, step back from it, and consider it, then you come to the right decision, realise actually there's 2 different sides to this. It's been interesting actually working with Xavier Griffin. I've spoken to him a couple of times about this over the last year and a half, although he's younger than me, he's the current president. Just seeing the way he's really developed a fantastic unit down in Barts, and he's just taking his time and he makes the right decisions and speaks. So that would be my advice. And just don't worry too much about the past or the future. Live in the now, but make the right decisions and keep realising that you're in a very fortunate position in terms of what we do. So, and don't lose sight of that. So Andy, big data sets are probably something I see as the future, because if we can link and connect all the big data on the patient, what happens to them pre-hospital, their comorbidities, their pre-morbid state, hospital journey, hospital injury, everything, right through to, I've got a big interest in sort of machine learning and big data outputs, because I think there's lots we're missing.
What about the genomic data that we have? What about all the blood data, the phenotype data? What about all the observations that the hospital just records passively? Yeah. All the anaesthetic machine data. Why isn't that all collected into a central system that then a algorithm that we've designed to analyse all that data start to predict outcomes, for instance, for us?
Yeah, so I mean, I think what we need to do is you set something up properly. You've got to work out in advance. Again, maybe speaking a bit, don't make a quick decision, as in you want to start something to look at it, but actually set your baseline up, looking at everything that you could potentially look at, and then obviously you monitor it prospectively, and then you can evolve with that. For example, the hip fracture, the white hip fracture group is an interesting study, isn't it? What they've done is essentially they're recruiting patients. This is an expanding, prospectively collected database that I'm sure they're improving in terms of their outcome measurements, but they've run, what are we up to now, white?
20-ish.
Yeah, so they've run 20 trials from this, looking at various things. Now, they haven't had to set up randomized control trials and all the expense and stuff that goes with those trials. They've actually just been able to run with it. And I think that's the advantage. You know, we've got the National Hip Fracture Database, we've got a National Joint Registry. The weakness comes when people think the data is poor. So, for instance, the HES database is often criticised for, well, it's a great database, but what's going in is inaccurate, so it's not accurate. So that's just out there. People just assume when people present HES data that it's not great. And that's a shame. So whatever we're doing, it needs to be set up properly so that when people look back with some scrutiny, we can defend what we're doing. So the big data, obviously, is we can look at things quickly with large patient numbers and come to some good conclusions. Now, AI is going to delve into that and maybe tell us what's the important things to look at. So all that stuff that I only understood about half of it, Anwar, what you were talking in terms of the figures could be important. But, you know, you might think that, but what else is...
It's like a missed trick almost, you know. It's like, why do we not look at it? We don't look at it. You know, we don't understand the relevance of it. I think so much of it will be predictive.
Well, data talks, personal opinion. You know, it doesn't. Somebody said to me, never let data outgun personal opinion. I think they were being sarcastic. Yeah. But it's, I think, it's data talks, and if you've got evidence,
absolutely.
And that's
but I mean, the issue is that we've currently got a system where the data integrity, as you mentioned, is driven by humans.
That's right.
Right. So we've got to put this was done at this time, etc. We've got to start relying on more objective data. That's why I sort of think that, it's either inputted live by a person and there's a standard way of doing it, which is what all the best practice tariffs and registries are built around. They are standardized questions, and it's great, but it still means somebody has to put it in. I think the sort of the future of this space is where you automate or reduce the admin burden as much as possible.
Definitely. So, for example, fragility fractures, right? So now, if somebody has a fracture, that data needs to be automated. If you produce automated, it's more efficient, it's more cost effective. What we can't have is high level nurses inputting that data per patient and saying, it's great, I've spent all week and I've got 200 patients, when actually a computer could look at fire. So it's about numerator and denominator. Denominator is everybody, numerator is what we're trying to look at, okay? So we've just got to get those numbers through the roof, and we can do that obviously by large data with AI stuff that's going to put that stuff in, transfer it from systems where it already is into where we want it, so that we can analyse it properly. But that's the challenge.
Wonderful. Thank you very much.
No
Andy.
problem.
Pleasure.
Lovely to speak to you.